Welcome, everybody. This lecture is the third in a series from a variety of voice AI experts that are really geared towards helping our current and future AI and ML workforce to prepare to work with voice as a source of data for artificial intelligence research. And these webinars are hosted by the skills and workforce development teams from the Bridge2AI Voice Consortium. If you're not familiar, the Voice Consortium aims to integrate the use of voice as a biomarker of health in clinical care to help us screen, diagnose, and treat a broad range of diseases. And our skill and workforce development team is comprised of a number of members from both Oregon Health and Science University, where both Bill Hersh and Dave Dorr lead, and then Washington University, where I have the good fortune of leading our group. So with that as background, I'm really excited to be able to introduce today's speaker, Dr. Thomas Kannampallil. Thomas is an associate professor in both anesthesiology and computer science here at Washington University in St. Louis, where he's also a member of our Institute for Informatics, Data Science, and Biostatistics. And his research largely lies at the intersection of computer science, cognitive science, and clinical informatics, including projects that focus on how to develop and evaluate intelligent computational tools for improving clinical decision-making and patient safety. Thomas is a prolific researcher. He's funded through a variety of institutes with 3 current R01s for the National Library of Medicine, National Institute of Aging, and the Agency for Healthcare Research and Quality. And apparently in his spare time between those 3 R01s, he also serves as an associate editor for the Journal of Biomedical Informatics and on the ONC and PCORI technical expert panels for health information technology. And of note, Thomas is also an elected fellow of the American Medical Informatics Association. And I'm sure he'll provide lots more background on his research. I could tell lots of embarrassing stories, but I will avoid the temptation to do so and instead turn things over to Thomas. So thanks for joining us today, Thomas.
Thank you, Philip. I really appreciate that. So today, when Philip and I talked, and I think with Andrea and also Rachel, I don't use voice as a biomarker, but this is more of what we have done in the last 3 years or so, a small part of my research, which is focused on voice as a platform for delivery, using a combination of AI and also delivery mechanisms and so, some of the challenges. And this is what I'm going to talk today is probably the only RCT of a voice-based system that's ever been done, to the best of my knowledge, and currently now published. So it was an interesting exercise, both in terms of translating a commercially available voice platform into a therapeutic delivery, into a therapy delivery mechanism. So there is a bit of informatics, there's a bit of design, there's a bit of a lot of RCT, and also a little bit of neuroscience. So I'll skip over parts that are that probably isn't the best for this group, but feel free to ask questions, and I'm happy to answer anything that I don't cover. So once again, thank you for the opportunity to talk today. Can you guys see my screen? I just want to make sure. I can't see the. Okay, all right. Some financial disclosures, none of which is related to this work, and also research projects. So when we started this project in 2018 or so, it was just an idea. The biggest problem we were trying to address was that were there effective mechanisms for delivery of therapy that could reach a broader population? As most of you know, or many of you know, the prevalence of depression it was significantly high even before the pandemic, and it's now approximately 32%. And same's the case for anxiety, and a large proportion of the patients who have depression and/or anxiety are undiagnosed and more concerningly untreated. And this affect's actually much higher among minorities. The challenge with treating depression and anxiety is multifold, and one of which several of you might know is lack of availability of providers for doing this. There's also issues related to time and transportation, the stigma associated with it, and also a preference for psychotherapies compared to pharmacotherapies. And even though proven pharmacotherapies exist, their use is sort of limited by a number of factors, including insurance reimbursements. So, you know, almost all of you would have encountered some version of the mobile-based tools that have been available over the last, I want to say, last 3 to 5 years. And various varieties of these tools have shown different levels of efficacy in very, very small scale studies. And over the last 3 years or so, you've also seen various chatbots. A popular and common one that's been widely used is Vobot. Vobot had a trial, which is essentially delivered on mobile sort of platforms in order to and interacting with patients with or without AI support in order to deliver some sort of psychological support. The problem across the board is that there's very weak evidence. This was from 2020. This systematic review and meta-analysis was from 2020, which showed that there's really very weak evidence for depression and/or anxiety symptoms improvement with chatbots. There's also high risk of bias across these studies, where very few studies showing significant effect, and the measurement and the heterogeneity in some of these studies are also considerable. So this brought us, to the idea, especially in around 2018, 2019, can Alexa or any number of those devices that we have available, Siri, Cortana, be used for delivering therapy? There's a lot of hype around this, but if you really dig through the literature over the last 3 years, on the literature in general on voice-based devices, there's really been nothing. Most of the work has been on, can it do certain tasks, and is the information that's provided by these devices accurate in some of these tasks? And across the board, the best sort of the most advanced in terms of the development have been ideas, mostly architectures, without actually going into whether they could be used for delivery of therapy or any sort of systematic interactions. The summary, across the board, was that they're essentially meant for task-based conversation. For example, what do you typically use your Alexa for? What's the weather? Or send a message. The infrastructure is also not developed for continuous conversational threads. It's essentially ask a question, get an answer, maybe ask a follow-up and answer, and it's done. The technical infrastructure, irrespective of what Amazon or Google Home or any of these device developers tell you, the infrastructure is minimalist. So there's a considerable effort that's required in order to build tools on top of them. And the studies that have existed, even of those papers that I was briefly mentioning, very rudimentary, not even at the level of a pre-post. There's certainly no randomized trials that are available. So what would really be needed in order to, so when we started the discussion about how can we convert one of these platforms, and there was a choice of platforms to be made, but in addition to that, what was needed to be done in order to make this work in sort of a patient setting? What we needed to do was not there is a considerable technical challenge, but more important than the technical challenge, and that we dealt with a lot, was how do we build that human-robot communication that would seem cognitively plausible or real? How do we build sort of those guardrails that can prevent conversations from going overboard, or controlling the conversation that's aligned with the therapy fidelity? These were sort of the pragmatic challenges. So this was really sort of human AI interaction before human AI interaction was a thing. So again, the challenges we've sort of summarized in this article in NPJ Digital Medicine a few years ago. And that actually led to building our sort of prototype pilot application, which was then eventually funded through the National Institute of Mental Health a few years ago. And so this came to the idea that we built this complete application. I'll go to the description of how we built it and what sort of structures are. But the goal was to conduct a pilot RCT, sort of a mechanistic study for treatment evaluation of the application on clinical outcomes. We had two with two outcomes, which was basically, did the intervention with the voice-based intervention mitigate depression and anxiety symptoms over a period of time when delivering PSD? And I'll talk about the PSD as a problem-solving treatment, which is a psychotherapy that was used, and also a little bit into the neuroscience folks. So if folks are interested, I'll talk about some of the neural targets, a priori neural targets, which related to emotional reactivity and cognitive control. Wanted to look at the activation of those, as is common in sort of mechanistic studies. Any sort of questions before I can't see the chat, so please feel free to ask questions if there are any. Okay. So what we designed with the voice-based platform on Amazon Alexa platform was, we call it Lumen. It's a coach for delivering PSD. It's and PSD, or problem-solving therapy, is a 7-step process where the user-driven therapy, where the coach acts as a guide. It's a 7-step process where the users identify a problem and they identify possible solutions for the problem, evaluate the solutions and the solution choice, and develop an action plan, and then review progress before going into how to implement that. So it's a very structured process. It has been widely evaluated in with human coaches and shown efficacy in both depression and anxiety outcomes, and also in sort of other sort of integrated interventions. The advantage of PSD with the sort of voice-based delivery platform was that it's a very structured process, and it also allows for the coach to act as a guide. So in the sense that the coach is not interfering in the conversation, but guiding the conversation such that the process is followed. So the therapy fidelity or the treatment fidelity is evaluated by if the problem step processes are followed. So it provides an opportunity for these sort of tools to act as a guide, which is one of the reasons why we thought it could be done. And I'll come back to this again, but the actual dosage, so to speak, of PSD is sort of eight sessions, which are delivered. The session 1 followed by in 4 weeks, followed by biweekly sessions for the next 8 weeks. So it's an 8-session therapy. But since we were running this as a trial, you do a session. We had a training session and did with an introductory session 1, followed by in between there was scheduling, rescheduling reminders. They had to do PHQ-9 and GAD-7, which are surveys for depression and anxiety. They also were sent EMAs and surveys on their phone, and I'll describe all of those processes. And then after session 1, sessions 2 to 8 was each session was aligned with the problem that they discussed and went through the 7-step process of identifying a problem. So I'll get into so how do we design Lumen? So I want to start backwards. It started with the idea. It started with how we deliver it, but then there's a whole sequence of development underneath it that I'll go through. Essentially, we had to design 2 things. On the platform, on the Amazon's Alexa platform, we had to first design the conversations. The conversations had to be managed in terms of state, where it had to keep track, because this was not a one-on-one one conversation and over. It was like a full conversation that usually went between 15 and 30 minutes, based on post hoc evaluation. So every time, the most challenging part of this design was to build and manage the conversational state in the process, and towards this we had a PSD, or a problem-solving therapy engine, which is managing the state. And then the next part was actually managing the context. So, even though the sessions were separate, you had to manage the situations between sessions. For example, what was the plan that was developed in the previous session for the problem that was there? How do you present that? The following session started with a review of how the patient followed the plan. Or not, or whether they were going to discuss the same problem or not. Also had to combine with, every session was started with a PHQ-9 or a GAD-7 survey in order to assess their current state and their depression and anxiety. So it had to be allowed. So it had to be aligned to those processes. In addition to that, the other part of this was, this was run as a trial, so you needed to with you needed to connect with systems that could manage this as a completely remote trial. So, the EMAs and the scheduling and the rescheduling. There are things that I've not spoken about of how difficult it was to sort of translate into the Alexa platform, but things that you do not imagine. So, for example, with a human coach, you can actually tell them, stop, I need to go to the bathroom, or I need to take a break, and I'll come back. With a device like this, initially when we designed, we had no resume and pause, so we had to incorporate these sort of very complex mechanisms of, essentially software design mechanisms in order to manage state and to pause and how long it could pause. And Alexa had rules on how long you could take a break between sessions. The last part of this was how to deliver this. There were all sorts of privacy and ethics questions, and I'm not going to get into that, but I'm happy to have a conversation about that on how to deliver this. The initial idea was we thought we'd give people an Echo device, which is $35, but there's lots of pragmatic issues in order to do that as a device. So what we did was we thought of this delivery platform as a device as a therapist idea, in the sense that the Alexa app was embedded in an iPad with all sorts of other sort of monitoring things that they could send, like text messages that they received, and surveys that they had to complete. And I also want to add the entire trial was run as a completely remote trial with almost no interaction with users. So it in terms of a very simple, very simplistic representation, the Alexa app was embedded in an iPad, which had all sorts of underlying architecture that was connected on AWS. They also had connected their cell phones, which they received reminders and things. Also schedule and reschedule their appointments with the virtual device using the Alexa app, which was also connected through various forms of AWS features in order to schedule, reschedule, calendaring, all sorts of things that made this in such a way that the entire platform was a single device. So essentially, what the participants got at the time when they went through they consented and agreed to participate was this iPad. I don't know if you guys can see the iPad, this is the actual iPad, which is given to people, and you could see the different sessions that were marked on this, and what to do in each of those sessions. And this was sort of the cover page. And they also got a workbook they could keep track of their notes in case they wanted to. So this was a combination of things that they received, and this was it. And they came in for the first session. They went through a practice session and training. I'll talk about the imaging things that they did after that. After that, they were on their own. And in general, I want to say, except for like a few sessions where people had some issues, in general, these sessions, people figured it out on their own. Before we ran the trial, we also ran a pilot, a formative evaluation study with 36 participants. Lots of issues were identified, especially not all of it was under our control. Some of it was mostly related to natural language understanding for these devices, especially for those with accents and even slightly different accents, sort of ambient noise issues. Some of the other things were sort of the mechanical way of delivery, sort of robotic way of delivery, which has improved over time, but still those sort of pragmatic issues related to voice delivery, and the inflexibility of the platforms were also some of the issues released. I'm going to go into the RCT, but I want to pause for a minute to see if there's any sort of questions on the tool / the platform infrastructure. All right, so I'm going to talk about the RCT. The RCT was run. We started recruiting in April of 2021. The eligibility criteria were 18 years of age, mild to moderate depression and/or anxiety, and as the participants had to come for 2 visits, essentially neuroimaging visits at baseline and at the end of the study. The end of the study period was 16 weeks. So they came in, got the device, went through training, had a baseline visit, and then at the end of the study, they had to come back in and they were compensated for the participation. And I can talk a bit more about how the compensation was handled. So the randomization was done in a 2-to-1. Again, remember, this was a pilot RCT. The randomization was done in a 2-to-1 ratio. The waitlist control arm participants received the waitlist control arm participants only received the EMAs and surveys over the 16-week period at exactly the same times the intervention arm received too. The waitlist control arm folks could choose to receive the Lumen intervention after the study period, meaning after 16 weeks. I think about 6 of them went through the process after that. So the Lumen protocols, essentially, the PSD was an 8. People had to do 8 sessions, 4 weekly followed by 4 biweekly. And as I said before, session 1 was primarily introduction and getting an idea of how to use it, and also how to go through PSD as a system. And in between sessions, they received reminders about their next session, and also had to complete PHQ-9 and GAT-7 prior to that. And there was also weekly EMAs and end of surveys. And sessions 2 to 8 were almost similar, essentially reviewing the progress which started from session 3. Basically, what did you do last time? What were the steps? How were you successful or unsuccessful? And then you either start with the same problem if it was not successful, or start a new problem that they went through the process. It's also a sort of a behavioral activation component to this. Again, a small part of planning activities. The primary clinical outcome of interest was, changes in depression and anxiety symptom scores measured by the HATS Depression and Anxiety Survey, essentially measuring depression and anxiety and overall psychological distress. And also the other part of this was the neural targets, which was in some ways for our trial this was pre-specified neural target measures that was identified through a previous face-to-face study in terms of how those targets were. So essentially, these were transdiagnostic phenotypes for dysfunction for both depression and anxiety. And our 2 primary regions of interest was the amygdala for emotional reactivity, and then the dorsolateral prefrontal cortex for the go-no-go task for cognitive control. Not going to go into the details of how the exact experiment was conducted. Basically, folks had to view for the emotional processing, the emotional reactivity threat phases over either conscious processing, where the same image was shown over or 10 images per set. One image, the same image was shown over a period of 10 seconds, followed by a neutral image, followed by these other blocks of images related to threat, anger, and fear. And in non-conscious, for 100 milliseconds, an image was shown, and this was different images over a period of time, actually activating different parts of the brain. The go-no-go task was essentially looking at inhibition and impulse. Inhibition versus impulse, which have known to be markers for both depression and anxiety. So the task was pretty simple, but for every second, little over a second, people were shown either a sign that said press, and they had to, in green, when they had to press a button, and if it showed in red, they had to inhibit themselves from pressing the button. So essentially, our metrics were both reaction time and the number of errors on task. Again, the focus of both of these tasks were the activation of specific regions of the brain related to both emotional reactivity and cognitive control. So in order to validate this, we also had folks had to complete, participants had to complete self-reported measures related to both emotion and cognition. So for the emotion, we had the PANAS, which is a positive and negative affect scale in the Penn State Worry Questionnaire, and had a bunch of measures related to cognitive control also. So the statistical analysis plan was essentially, it was a pre-specified statistical analysis plan. All participants who had a follow-up at 16 weeks were included. The analysis was focused on basically finding out a difference between intervention and waitlist on the effects on both the neural targets and between 0 and 16 weeks, changes from baseline to 16 weeks. And this was also We also ran correlations to see the association between the neural targets and the changes in the self-reported measures. Since this was an RCT, we used Cohen's d as a mean difference between pre-specified mean difference between groups. Cohen's d greater than 0.3 was considered as a meaningful difference for comparison. Pre-specified, same thing with correlation. We used an R greater than 0.4 as a threshold for assess the differences. So what did we find? So 63 participants were randomized. As I said before, this was a 2-to-1 randomization with 42 in the intervention arm and 21 in the waitlist control arm. The interesting part of this was essentially how successful we were in keeping people in a trial, which we really feared that people would drop off because of the challenges of the platform and how the therapy was delivered. But for all those of the 63 participants, 61 were assessed at 16 weeks, meaning that 61 participants completed the visit 2, who also completed visit 1. 38 participants completed at least 4 sessions, which is considered the minimum, which is again over 90%, and 31 out of the 38, which is 81%, completed all 8 sessions. So in terms of keeping people in the trial and completing the study, this was to me one of the most successful trials that I've been involved in. So it was very promising in terms of the viability of not just the infrastructure, but also in its delivery platform and how we sort of created this infrastructure in order to make this work. So what did we find in terms of the primary outcomes? Both depression and anxiety outcomes, we found greater improvements in depression, anxiety, and total psychological distress in the intervention compared to the waitlist. All 3, as you can see here, all 3 Cohen's d were 0.3, which was what we had predetermined. We also ran a mediation analysis. What we found was that the intervention group had greater improvements in both depression, anxiety, but the effects were more significant among women, those with college or lesser education, and among non-white participants, which was also promising, showing that this had an effect among certain minoritized groups. In terms of neural targets, the negative affect circuit, which is, as I explained before, was the amygdala circuit. We did not find an effect on the emotional reactivity and did not meet the pre-specified threshold of Cohen's d of 0.3. However, but I do want to point out, like, the right amygdala did show, the directionality of both in the right amygdala was in the right direction, the negative, even though it did not meet the pre-specified targets. But for cognitive control, we did see the right dorsolateral prefrontal cortex did show the pre-specified Cohen threshold of 0.3, showing that there were meaningful decrease in the activation of the cognitive control circuit for those in the intervention arm, showing how high reliability in some of these in these metrics. In terms of the treatment effect with self-reports, this both the positive and the negative affect scores did not, similar to the negative affect circuits, did not show did not meet the threshold. But some of the criteria, the self-reported measures related to both problem solving, related to cognitive control, did meet the threshold for a pre-specified threshold of Cohen's d of 0.3. I also wanted to say that the right DLPFC, which was the cognitive control circuit that we looked, was correlated with the social problem solving and negatively correlated with the avoidance scores, which is again highlighting how the self-reports were also reflective of what the neural circuit, what the pre-specified neural circuits were showing. Gonna skip that, but I do think that one of the interesting things about the other interesting things about, even with such as very low threshold intervention where The interaction with the robot was in some ways in some ways not perfect. The change in depression score was greater for those with lower health literacy, similar to the mediation that I showed, with respect to women, with respect to non-white, and those without college education. This was another interesting factor for that we thought was can have meaningful impact. So I'll stop here for a moment. I said a lot, and I have a lot to talk about in terms of what this means in terms of voice as a platform, but I just wanted to pause for a second. Okay. All right. So what do we find? And I said a lot of things. I wanted to highlight a few things, right? What do we find in this study of fully virtual, a fully voice-based with no assistance with a human, a virtual coach, which was delivering problem-solving therapy, showed improvements in both symptoms of improvement in both depression and anxiety and total psychological distress in 16 weeks with just the intervention. There was also meaningful changes. Since this was a mechanistic trial, we were looking at the meaningful changes in a subset of neural targets. At least in a subset, we did find meaningful differences, showing potential ways in which this can be used. Also related to this, the self-reported measures also were correlated with these, again highlighting how this can be used. But more importantly, there are some sort of interesting insights as we go into the next phase of this efficacy trial, and one of which is that over 80% of the intervention participants completed all 8 sessions. To me, that's probably the most important finding from our one of the more important findings, that even an intervention which has a fairly low threshold and a high sort of learning barrier, people were confident enough to use it over all 8 sessions, showing reason but why we showed efficacy in some of the outcomes. The effect was more among marginalized groups, which also points us to the fact that potentially for those with lesser access to mental health resources, or for those who did not have any sort of mechanisms for reaching therapists or mental health providers, this provided an easy on-demand access solution, even though the sort of benefit was maybe potentially not very high. And harder than talking to a human. It also, definitely the efficacy trial, which is currently ongoing, will tell us more about what this will mean as a digital mental health intervention. But the value of these sort of tools provides the sort of the pragmatic viability of using this. So what does this mean in terms of voice as a platform? Every phone or mobile device now has a voice integrated platform, and this broad availability of these platforms provides opportunities for people to deliver these to deliver these sort of therapy mechanisms through these platforms. And one of the things that's commonly said about chatbots is that it's harder to type, and it also excludes certain age groups where older adults are less likely to use some of these tools. We have another planned trial that we're sort of bringing together in terms of using these sort of devices, these especially PSD for older adults with depression and anxiety, which challenging in other ways in terms of delivery. Also, the other important factor is the on-demand availability of this. The reach and availability of these psychotherapies can significantly be increased with the use of voice. The challenge primarily lies in that we have to rely on these consumer platforms, consumer-based personal assistant platforms, in order to deliver this. And that sometimes is a challenge. And I can talk probably 2 hours of how we had to string together various approaches in order to just register these devices. Amazon changes its rules in terms of what skills are, and how the skills can be delivered, and what are sort of the priorities in terms of what can be downloaded from their store. There's also challenges for integrating external things, like, for example, RedCap, which was integrated with this in order to run a trial, from having it as an app. Our data safety monitoring board had to monitor these PHQ-9 and GAT7 scores, which is probably not possible in a broadly available system. To me, the on-demand availability, which people we had, I'm not going to talk about this, but we had post-study interviews with Lumen participants that showed that the on-demand availability was one of their most important things. When people were in a crisis, or potentially thought they did not have solutions, they'd learned the way in which to adapt, like PSD. PSD is like a tool, and the goal of this 8-week session, session therapies is to give people a tool to solve their problems, which is what most therapy sessions are for. And this helped them create that, and this on-demand availability helped them in order to do that. What we showed, not just in terms of the symptomatic outcomes, but also the adaptability of the tool and its sort of broad availability in doing that. There are several other interesting things that we found from this. Like, we did a post hoc analysis on how people adapted to the system, right? Like, so early on, the first 2 sessions were hard. There were lots of breakdowns where they had to stop and restart from the beginning. But by session 3, they were back to session 3 and session 4. They figured out how the tool worked, and they adapted ways in which to interact with it such that the tool doesn't, break and it restarts from the beginning for things. So these were the kinds of things, like, pragmatically, that people figured out. And by session 6 and 7, I mean, everybody, like, sort of breezed through the entire process. So lots of things we learned. We integrated several of the changes in the now ongoing efficacy trial, where we've recruited about 122 as of yesterday out of the 200 recruited. So we'll see. That also has a third arm for a human coached arm. So we'll see, and it's a non-inferiority trial. So we'll see how the results pan out. But in terms of when we designed this and where we are right now in terms of these voice applications, I think we're in a different world. Even though the developments that have been made are not explicitly translating into platforms, there are a number of reasons for it. Several of the big companies, including Amazon, have sort of paused on their research and R&D on these sort of tools. So it'll be interesting to see what sort of developments we see in terms of delivery, natural language understanding, folks with in terms of accents, features in order to build things into so things like emotion recognition from voice. There's a lot of work that's been done, but it's very hard to implement these in sort of very consumer-like platforms. Like I said before, this was PSD was with what our team was very familiar with, and I had colleagues who had done extensive studies, especially at the University of Washington, with PSD and the PEARLS program. So we knew exactly how to translate it into Alexa, and the goal really was a combination of software development, understanding of artificial intelligence, and more of a sort of an interaction design, so to speak. How do you design communication in such a way that that you can go through not just what's the weather type of conversations, which are very task-based, but more into a platform type conversation that can lead to a sustained mechanism of conversation. But I will say the challenges exist. Natural language understanding, even in the efficacy trial that's going on now, is a problem, especially for those with language understanding or issues with internet connectivity. Platform changes are a challenge, and it happens. We've tried to maintain platform independence for platform. We've tried to maintain the platform architectures consistently, avoided updates. So there's lots of challenges with running a pragmatic clinical trial with sort of changing platform dimensions. So I'll stop there. Our study was published late last year in Translational Psychiatry. Got a lot of press in terms of what this means and how it can be used. So stay tuned for more. This was funded by NIMH, which is a multi-institutional study, primarily started through UIC. We have WashU, Penn State, and Stanford were collaborators on the study. I'll stop there. Thank you very much for having me. I know this is a little different than voice as a marker, but more along this along what I try to present to this broader group who's interested in voice as a mechanism and a platform. So I'll stop there. Happy to take any questions if there are, and thank you for having me.
So thanks, Thomas. I really appreciate it. And so if people have a question, you can either raise your virtual hand or you could try to put it in the chat if you'd like to. Maybe while you all think about your potential questions, Thomas, I'm gonna take the prerogative of being the person that introduced you to ask the first question. So, it's interesting. You and I have talked a lot about some of these interventions using voice assistants as a way of delivering various sort of care paradigms to patients, and this is a great example. It had the ability to get recordings of individuals' interactions with the voice assistant back. And actually sort of assess how sort of variations in sort of the nature, quality, dynamics of those recordings look. Could you imagine that as sort of a future direction for this work? And obviously I'm asking for a very specific reason, which is sort of it's kind of the natural extension of what you're doing to what this group is focused on.
Yeah, so the short answer is yes. We've never saved them. It needs, because of the way the BAA was structured in order to run the study. But in theory, it's, so we have the entire text. Amazon does not store the voice unless the actual interactions beyond a certain point, unless it's explicitly set up, right? So in theory, let me take it back. So we're going to put this in the Amazon store in the hopefully next month. It has to go through us the updated version of the platform. It's going to go into the store, and once that's done, it's much easier to save these voice if he's checkbox X for checkbox certain things. It's very simple. We have the entire text, the actual natural language of this associated with it. But we did not save it. But it's an easy thing to do. We just did not want to do within the confines of the RCT for purely pragmatic reasons. IRB, all sorts of very narrow issues with respect to what Amazon will use this voice for. But yes, this is, I mean, if somebody wants to use this, in a non-trial setup, we can talk about it. It's not very hard. I have another R01 where we're using this in a different, just submitted it for a different context. So that will be another use case for this.
No, that's great. All right. Other questions from the group? I get to ask Thomas questions all the time, so it would be unfair of me to use this time.
This may also be outside the direct realm of this group also, which I understand.
No, Bill's got his thinking face on. I'm pretty sure he's going to come up with something soon.
Well, as long as you've put me on the spot. Very nice talk, and I appreciate the challenge of doing these studies, and it's great. And actually, as Philip would know, I'm an advocate of that we need to really do this in AI. I can't. I think your study is very well done, and I can't really criticize any aspects of it. But one thing that goes through my mind, and maybe it's because I was recently reading a book about telehealth, and talking about how telehealth systems are, designed to help, presumably people with less access to services and resources. And at least during the COVID-19 pandemic, what telehealth help was people like us, who have access to resources, good technology, well educated. Do you see any? So let me maybe ask the question. Do you see any issues with equity issues? And again, not to be critical or anything, but how we can expand to larger audiences.
So can I take a step back and answer this in a much more broader perspective, right? This is one example. I have another trial that's running. So essentially, I'm interested in behavioral medicine, right? Like how you can use informatics and the EHR and sort of the mechanisms for delivering behavioral medicine. The problem that we have currently, not the problem, the situation where we have currently is that, you can prescribe any medication you want, but if you want to prescribe, let's say, PST for people which have shown efficacy, or a weight loss mechanism, or for example, the DPP, or any of these behavioral sort of interventions, we have no mechanism to do it. And the reason why we have no mechanism to do it is because all of the trials that have happened, which have shown like variety I mean, you could write a systematic review on some of these behavioral interventions. They're not at the point of care, meaning that you cannot order a PST or a Lumen session at the point of care. So if you look at the broader question, this is sort of my philosophy about this, is that you cannot get to, if you can't bring it to the point of care, because you cannot monitor this. So what you're trying to do is that not only do we have to build these interventions within the EHR using the MyChart and the versions for monitoring, we also need ways in which these tools are attached to the ecosystem. Like you mentioned, the equity issue. If you can show the value, $35 for an Echo device that can reach a patient, and we have mechanisms in which they do a PHQ-9 score that you can monitor, that score comes back, and that you have a longitudinal way in which you can track these patients, I think then we're in the business of bringing behavioral to the consult. Like you mentioned telehealth, right? The issues with telehealth that we saw are the inequities of care and all of those things. But there's also differences. Like Julie and I have a NLM-funded study, which is actually looking at what are the differences in which how physicians use the EHR during telehealth visits, which is fundamentally fascinating in terms of the differences, right? So you're also changing clinician behaviors in these processes, and how those clinician behaviors are affected is what they see and how they use it. So I think you've brought up a very complex problem, and I think the idea of, if you want to bring behavioral medicine and some of these tools that can reduce the inequities in care and care processes, I think we need better ways to attach these devices and these tools and these frameworks back to EHR, and sort of, we're spending billions of dollars at every institutions for maintaining the EHR. We should be able to build infrastructures in order to connect other things that we want to, sort of democratize care infrastructure to build it back. I don't know if that answers. This is just my philosophy about these things. I don't have any solid evidence that's
great. I mean, we have a lot of inexpensive interventions, but for whatever reason, we would rather spend the money on people in the hospital and so forth. So I completely agree. Thanks.
All right. So any final questions for Thomas before we wrap up? Just easy questions like, what would you do with the recordings if you had them, and how do you address health equity? So I appreciate that we kept it very simple for you, Thomas.
But Philip, if you're really interested in those recordings, I think there's a way to get them.
Oh yeah. And I think one of the things that this group is working on as well, like through the Voice Project, are better tools to cover a spectrum of needs, from how we consent patients to collect recordings to, how do you collect corresponding data alongside them, to how do you store and, analyze them. And of course, for us, we want to make sure we're teaching people in the skill and workforce module sort of that whole life cycle. So people are thinking about, like, where does the data come from how do we make sure it's fit for analysis, how do you pick the right tools. And I think what you did today was sort of introduce an example of, you know, other than projects that are specifically designed to collect voice, there are many other applications where voice is already being collected in a healthcare context and could be repurposed to either improve those interventions or support other interventions. And that's one of the reasons why I wanted to come and talk to the group today. So, all right, why don't we give everyone 7 minutes? I'm sure people have at least, you know, 5 to 6 emails to respond to that have accrued during this talk at a minimum, if I was going to do the ratio. And I'll just say again, thank you, Thomas, for taking the time to talk with us all. And then Rachel, any final logistics, or are we okay?
We are okay. They're actually just appeared in the chat.
Oh,
a question.
Yeah,
yeah, from
so
Stephanie.
Here, I can read it. I can read it. Sorry, Thomas. You thought you were off the hook, but you are not.
Yeah.
So it
Sorry,
says, very nice talking.
Yeah.
Oh,
sorry,
do you want
I'm
to go ahead
having
and ask Stephanie? Yeah.
I'm having issue with my camera, so I just posted on the chat.
That's okay. Did you want to just say your question for Thomas, or?
Oh yeah, so determining the level of therapy intervention a patient may need is a very complex process that, you know, many psychologists, psychiatrists haven't you know, extensive studies on. I was just wondering, how does this application kind of assist the patient finding the right tool or directing them to the right resource?
Right. This is what I was saying earlier to Bill in terms of, you know, this is not a patient-driven mechanism. The entry into this tool is essentially, you know, somebody is diagnosing you with mild to moderate depression and or anxiety. And sort of the idea is that you're being prescribed this intervention of a 8-session intervention where they go through this process. So again, that part of identification and of the diagnosis or the process, the therapy or the intervention that's needed is outside the scope of this tool. But this is basically, if you're identified with mild to moderate depression, which is about 30% of U.S. adults, then hey, here's a mechanism. The goal is that it's reducing the barrier to getting to this intervention, which is otherwise being affected by, for example, you know, transportation burden or getting to a therapist or even just finding a therapist. Like, you know, I can tell you in you know, these days, finding a therapist can take up to 6 months, depending on where you're looking at in the regional. So again, it's not looking at diagnosis. It's looking at post-diagnosis sort of management. Does that help in terms of clarifying?
Yeah, thank you.
I also want to say this is, you know, this was sort of my accidental foray into this space. This is not my primary research. I got into, I mean, I don't know how many clinical informaticists are clinical trialists too. This was an opportunity for me to understand trials. So now I feel like I'm running my 3rd RCT right now. So it felt this was of an exposure to that. So this is sort of a learning experience in a new platform. The reason I got into this was primarily for the software, the AI platforms that gave me an opportunity to build on some of these things. But it's been fascinating and very fruitful, so to speak.
Yeah, to be honest with you, Thomas, I think you're pretty much in a position now where you no longer can say it's an accident because you've done it more than once. But nonetheless, I do think this is an interesting dynamic, which could be a whole nother talk, which is this idea that as informaticians and data scientists, we need to actually do this type of research in order to build the evidence base for AI-driven interventions. And I think that actually goes to a comment that Bill alluded to just a minute ago as well. So, all right. I see no more questions. I see a few more compliments in the chat. So I assure you they're all very positive, Thomas, since you can't see them right now. And with that, I think we can sort of wrap up for the day. So thanks, everyone.
Thanks a lot.
Thank you.